Good morning from Copenhagen, Denmark. We're pleased to be here this morning with Dr. Steve Sarkisian from Oklahoma City, Oklahoma. Thanks a lot for being here today.
Welcome, John.
Now, Steve, I'd like to speak this morning with you about a glaucoma procedure called ECP, or endocyclophotocoagulation. Can you tell us a little bit about what this procedure is and when it's used?
Absolutely. So endoscopic cyclophotocoagulation, or ECP as we'll call it, has been available for many years now. And in fact, many would say it was really the first MIGS, or microinvasive glaucoma surgery, because it's something that can be done through the same wound as a cataract surgery wound, or done by itself. And really, essentially what ECP is it's a cycloablative procedure, but instead of the conventional thinking with the cycloablation, where you're going on outside the eye and treating a bunch of parts of the eye that have no business needing to be treated, it's visualizing with a camera the end organ, namely the ciliary body, and ablating not the whole thing, but really just the front third of it, and shrinking it and causing it to create less aqueous humor, and that's how it lowers pressure.
Well, Steve, I'm glad that you mentioned the use of the cataract incision. Is this a procedure that's done concurrently with cataract surgery, or can it be done independently on its own?
Really, it can be done independently. I feel quite strongly that if it's going to be done without cataract surgery, that it be done on a patient who is either pseudophakic or aphakic. I think that that's very important. If the patient is aphakic, that you have to make sure that you have an infusion cannula to maintain the pressure within the eye while you're doing the ECP. But most commonly, it is still something that we would perform with cataract surgery, because you're right there, and you already have the incision, and so it doesn't add very many steps to a conventional cataract surgery procedure.
Well, tell us, Steve, how does ECP now fit in to the vast armamentarium we now have, especially in the context of many new MIGS devices coming onto market? We have canal-based devices and subconjunctival space devices. Where does this fit in?
Yeah, it's an excellent point, and I'm actually a strong advocate for not limiting my options. And I take care of patients with glaucoma who not just have early glaucoma, but who have moderate to moderate severe glaucoma. And I want to avoid filtration surgery in almost everyone, even though conventionally people would get something like a trabeculectomy if they had advanced glaucoma that was progressing. Now that we have more than one MIGS procedure and they work differently, I believe that if you combine these MIGS procedures, you can have an expanded treatment armamentarium. You can go beyond just early glaucoma. So, for example, with the iStent, the only device available that it gets implanted, that was indicated for mild to moderate glaucoma. And really, ECP, when done by itself, is really a mild to moderate glaucoma treatment. But if you combine the two, they both work differently. One is an aqueous suppressant. The ECP is aqueous suppressant. The other allows outflow through the trabecular meshwork to function better. So they have a complementary mechanism of action. They both work differently, but together the pressure can be even lower. And so we're seeing a lot more of these combined procedures. And I see, once the CyPass comes out, which is the suprachoroidal implant that Alcon has, that's also going to be something that could easily be combined with ECP. So ECP is not going to go away. It also has certain indications that these other things do not. The other things are for open angle glaucoma. Patients that have more combined mechanism glaucoma or chronic angle closure glaucoma, you can still do ECP on them with cataract surgery, whereas those canal-based surgeries are really not indicated in patients that have chronic angle closure glaucoma.
Well, Steve, I'm glad that you brought up the idea of using ECP in combination with other various procedures and devices. Can you explain for us Is this a procedure, ECP, that is performed across the entire 360 degrees of the ciliary body, or do we selectively treat certain areas over others?
Well, that's an excellent point. You can certainly just, if you have a curved probe, just treat 270 degrees. I personally like to make a second incision and do the full 360 degrees, because there is added efficacy the more area that you treat. So if you treat the whole thing, you definitely have a persistently lower pressure. And often in my patients, because I'm a glaucoma specialist, not a general ophthalmologist, I have patients where they've already been maximally treated by a general ophthalmologist or an optometrist, and I'm really trying to give them a surgical procedure that's going to work as well as it possibly can. I'm not just trying to get them off one eye drop usually, but they usually have a higher pressure on drops, and I'm trying to get them lower. So I definitely believe that the 360 is better, but there likely will be more inflammation. A word about inflammation, though. ECP can cause inflammation, but if you're really careful about how you apply it, even when you do 360, if you don't pop the ciliary processes, you don't over-treat, and you're very cautious about that, then the level of inflammation post-operatively is actually fairly easily managed.
And as you mentioned, oftentimes this is being performed in conjunction with cataract surgery, when a post-operative anti-inflammatory regimen will be used for treatment anyway.
That's true, and I definitely up that regimen. I'll use a very strong steroid every 2 hours for the first 5 days with my ECP patients. And then I back off very quickly because I don't want to have steroid response. But there's a low incidence of steroid response with ECP, particularly in the first couple of weeks, just because you've ablated the ciliary body. So the eye can't necessarily build up that steroid response as readily because you've shut it down.
Well, Steve, I really appreciate your explaining to us today some of the benefits of ECP and how it incorporates into other various glaucoma treatments. Thanks so much for your expertise.
You're welcome.